This is part D of Chapter 7, and in this portion I'm going to spend a good deal of time talking about the pulmonary artery occlusion pressure, or colloquially known as the wedge pressure. Ironically, this seems to be everyone's favorite number off of the pulmonary artery catheter, but it is probably the hemodynamic parameter derived from the pulmonary artery catheter that is fraught with the most problems of both A, measurement, and B, interpretation. There is a variety of measurement artifacts that can ruin the pressure that you're trying to measure. That is, you're trying to obtain the left atrial pressure. And then once, or if you do have an accurately measured pulmonary artery occlusion pressure as a surrogate for your left atrial pressure, there's a number of problems that go into the interpretation of that measurement, and I'm going to discuss these in turn. So I'm going to refer to this as you'll see this abbreviation, the P subscript PAO, which is the pulmonary artery occlusion pressure. As I mentioned, it is fraught with problems, but it is still a useful measurement in certain clinical situations. Erroneous clinical decisions come from the occlusion pressure in both errors of measurement and interpretation, as I mentioned. I will discuss these in turn. We'll discuss the principles behind measuring an accurate pulmonary artery occlusion pressure, and then I will discuss problems with interpretation of just exactly what the pulmonary artery occlusion pressure means. So when the balloon at the tip of the pulmonary artery catheter is inflated, blood flow is ceased beyond the balloon, and a static column of blood is created between the distal port of the pulmonary artery catheter and the J1, or first junction of the pulmonary veins. So this is a portion, the J1 junction is the first junction, and it's about 1.5 centimeters away from the left atrium. And this is truly where the pressure of the pulmonary artery occlusion pressure is being measured. Accurate measurement of the pulmonary artery occlusion pressure requires consideration of the following. Firstly, like the central venous pressure, the pulmonary artery occlusion pressure will be affected by the physical relationship between the catheter tip and the transducer. And I discussed that in Chapter 6 when measuring the central venous pressure on, say, something from a triple lumen. Secondly, like the central venous pressure, the pulmonary artery occlusion pressure will be affected by intrathoracic pressure. It's somewhat different from the CVP, and I'll go through a slide next, actually, that will elaborate this. But certainly, and this is probably the most common error of measurement of the pulmonary artery occlusion pressure, and that is not taking into consideration the effects of intrathoracic pressure. And finally, the pulmonary artery catheter, the tip of the pulmonary artery catheter must be in West Zone 3 physiology, as I discussed in a previous slide, and I'll get into a little bit more of that in a couple of slides. So again, this is the marriage of the Campbell and Gaytan analyses. This is stolen from Chapter 3, and I hope to use this. It's going to be a bit detailed. But I think that you guys are all ready for it now that we're on Chapter 7 and you really appreciate the relationships between pulmonary physiology and cardiovascular physiology. So this is going to illustrate the relationship between changes in intrathoracic pressure, specifically an increase in intrathoracic pressure via Valsalva maneuver, and changes in the pulmonary artery occlusion pressure. So on the Campbell diagram here, again into the page, this is essentially a normal patient with normal pulmonary elastance, normal chest wall elastance, and normal dynamic properties of the lung. If you were to Valsalva, you are simply increasing intrathoracic pressure. That is, you're moving from FRC to a higher intrathoracic pressure here, from slightly subatmospheric to atmospheric. So it's kind of a baby Valsalva, but nonetheless it's an increase in intrathoracic pressure without a change in volume, which is the definition of the Valsalva. Okay, so there's with this, there's a decrease in right ventricular volume despite an increase in right atrial pressure. And that is demonstrated by this graphic here. So remember, as the intrathoracic pressure increased from here to here, the cardiac function curve shifts equally along that curve, okay? And now you have a new measured right atrial pressure. So you can see that your right atrial pressure has increased from here. With the increase in intrathoracic pressure, right atrial pressure has increased to here, but your transmural pressure has actually decreased, which means that essentially your right atrial and right ventricular volume has shrunk. Remember, the transmural pressure is a measure of the distending pressure of a distensible object, and as the transmural pressure decreases, as it has here, there's a tendency for the volume of that structure to collapse. So what has this got to do with the pulmonary artery occlusion pressure, you might be asking? Well, this is just, it's a little bit advanced. I'm putting it in here for a little bit of icing on the cake for this physiology. And I'm putting it in here because the decrease in right ventricular volume that you get with a Valsalva actually tends to, via ventricular interdependence, especially if the Valsalva is initiating during diastole, if you shrink the right ventricular volume as you have here, you'll actually improve the compliance transiently of the left ventricle, and now this red left ventricular function curve will actually shift somewhat up and to the left, and that's simply from diastolic, favorable diastolic interactions for the left ventricle. You've shrunk the right ventricular cavity with a Valsalva, which will temporarily and briefly improve the filling properties of the left ventricle and somewhat lower the pulmonary artery occlusion pressure. So this is the pulmonary artery occlusion pressure that you're measuring here. This line has now become pulmonary venous return, not systemic venous return. So the pulmonary venous return curve and the left ventricular cardiac function curve shift in parallel with increased intrathoracic pressure, and that is different from what we just saw, which, as we saw, was the increase in intrathoracic pressure of the right ventricle shifted the right ventricular cardiac function curve rightwards with respect to the systemic venous return. The same is not true for pulmonary venous return, and the reason is because the pulmonary veins and the left ventricle both reside in the thorax, and both will be submitted to the same increase in intrathoracic pressure, as opposed to systemic venous return, where you are increasing the pressure around the right heart relative to the systemic vein. So that will be illustrated here. As, again, this pressure is increased simultaneously, the pulmonary venous return curve and the left ventricular cardiac function curve shift rightwards with that increase in intrathoracic pressure in parallel. The left ventricular function curve does not shift relative to the pulmonary venous return because the veins and the heart are subjugated to the same intrathoracic pressure. So in effect, the transmural pressure of the LV is not changing with the Valsalva. Simply the pulmonary artery pressure is increasing in response to the increase in intrathoracic pressure. But again, this will introduce a systematic artifact into the measurement of the pulmonary artery occlusion pressure, and that is, as intrathoracic pressure increases, or decreases for that matter, the pulmonary artery occlusion pressure will similarly increase or decrease, but the absolute value of that increase or decrease will be meaningless in terms of the true distending pressure of the left ventricle, which is what you're actually trying to obtain from the pulmonary artery occlusion pressure. So again, I put that slide in to illustrate how an increase in intrathoracic pressure affects the right and left heart differently, how via ventricular interdependence the change in right ventricular volume will actually instantaneously change the compliance of the left ventricle, and how the increase in intrathoracic pressure increases the pressure surrounding the pulmonary veins and the left ventricle, so both the pulmonary venous return curve and the cardiac function curve shift rightwards, which serve to increase the pulmonary artery occlusion pressure and introduce again a measurement artifact, in that the increase in this pressure has nothing to do with the vascular distending pressure which you're trying to obtain from the pulmonary artery occlusion pressure. So this measured pulmonary artery occlusion pressure, as I mentioned, will be an overestimation of the true distending pressure of the left ventricle. And a couple of good clinical examples of where this might be seen is both intrinsic and extrinsic PEEP. So if a patient is a COPDer and they're huffing and puffing along and they're air trapping in the lower lobes, particularly in the lower lobes, as the lower lobes expand and compress against the pulmonary veins and left ventricle, the pulmonary wedge pressure will increase, but this has nothing to do with an increase in the distending pressure of the left ventricle. If anything, it will lower the distending pressure of the left ventricle. And you're simply you've simply introduced a measurement artifact from intrathoracic pressure, and it reflects nothing about vascular distending pressures. This is, as I mentioned, one of the most common problems with the measurement of the wedge pressure. And one way to get around this, and this is a very cute trick, this was introduced 6 or 7 years ago, I believe, by Jean-Louis Thibault. I hope I'm pronouncing his last name correctly. It's T-E-B-O-U-L. I thought this was a really cool idea, and it's essentially obtaining this index of transmission where you look at how much of a given application of airway pressure is transmitted to the vascular compartment. So how does one do that? Well, this is a pressure waveform that I stole from Chapter 1, and for review of the peak and plateau pressures, I suggest you go back to Chapter 1. But you can estimate the fraction of this airway pressure that's transmitted to the vascular compartment via this index of transmission. So how do you do that? Well, at end expiration, where you normally should measure your pulmonary artery occlusion pressure, you measure your quote-unquote wedge pressure here, make note of it, and then you do the exact same thing for your wedge pressure during a plateau pressure or an end inspiratory hold. So this is an end expiratory hold, measure the wedge. End inspiratory hold, measure the wedge. And for illustrative purposes, let's say that the difference between your end expiratory airway pressure measured on the ventilator, again, the end expiratory and end inspiratory are pressures measured at the proximal trachea by the ventilator. Let's say the difference between these two is 10 millimeters of mercury. Now remember, the pressure that you get off the ventilator is in centimeters of water, so you'd have to make that calculation in your head. So 10 millimeters of mercury, you'd have a difference in expiratory and inspiratory plateau pressure of about 13 centimeters of water will translate to 10 millimeters of mercury. Again, I'm just picking this number to make the math easy for illustrative purposes. So the change in airway pressure here is 10 millimeters of mercury. So let's say that when you measured your wedge pressure here, it was 5. And then when you measured your wedge pressure here, it was 8. Well, your change in your wedge pressure has gone from 5 to 8. That's an increase in your wedge pressure of 3 for a change in your airway pressure of 10 millimeters of mercury. So you can see here that this index of transmission is 3 out of 10, or 30%. So 30% of the airway pressure on the ventilator is being distributed to the vascular space. So this is kind of a cool number, because now you can use this index of transmission and apply it to different vascular pressures that you're measuring in the thorax to get a sense of how much of that vascular pressure is being made up of the pressure applied by the ventilator. Now again, the lungs and the chest wall may change in compliance, and there may be very dynamic changes in your pulmonary characteristics. So this index of transmission can change in a given patient over literally minutes or hours. So you can't just do this index of transmission on day 1 and apply the same number to the same patient the entire time. It's going to be a very dynamic variable. But it's a neat idea of applied physiology and how you can get a sense of how much of the ventilator pressure is being applied to the to vascular pressures. An important caveat to this, and I will admit that I've cheated on this, is that you cannot use this analysis for a right atrial pressure. This cannot be applied to the CVP. This can only be applied to the pulmonary artery occlusion pressure. And the reason is a bit complicated, But it's essentially that as you increase thoracic pressure, you will change your right atrial pressure, not simply as a function of changes in intrathoracic pressure, but you will also change your right atrial pressure as a function of changes in systemic venous return. Remember, as you increase thoracic pressure, you're changing pressure relative to the systemic veins. So the change that you may see in the right atrial pressure as a response to a change in airway pressure may not just be a result of the changes in airway pressure, but in fact changes in venous return as well. You do not run into that same problem with the pulmonary artery occlusion pressure because, as I mentioned, pulmonary venous return, the pulmonary veins and the left ventricle are subject to the same intrathoracic pressure. So you negate that variable of changes in pulmonary venous return with a change in airway pressure. Now you may say, well, you just told me that increasing your airway pressure may change the diastolic properties of the right ventricle, which will change the diastolic properties of the left ventricle via ventricular diastolic interdependence, and that is true, but those changes are assumed to be transient and minor, and that you can apply this index of transmission variable as a relatively accurate marker of the transmission of airway pressure to pulmonary vascular pressure. So I think that I've talked about this, but you have to bear in mind that this method again requires a completely passive patient with the ventilator. So the patient has to be either paralyzed or very, very sedate. Because when the patient is bearing down or generating significant respiratory effort, the use, as I mentioned, of the pulmonary artery occlusion pressure as a marker of LV filling pressure is exceptionally flawed. So also, as I mentioned in a previous slide, the pulmonary artery catheter must be in West Zone 3 for accurate measurement of the pulmonary artery occlusion pressure. And as we know, the reason is as this balloon is inflated, there has to be a static, unchanging, uninterrupted column of blood from the tip of this catheter all the way to the J1 point, or essentially the left atrium. And as you can see here, let me reanimate that for you. The reason is because if the pulmonary artery catheter were in Zone 1 or Zone 2 physiology, really Zone 1 physiology shouldn't exist in euvolemic or certainly hypervolemic patients. Zone 1 physiology only really exists in truly hypovolemic patients. But if the pulmonary artery catheter ended up here or here, you would then be measuring alveolar pressure because with a change in lung volume or a change in your transpulmonary pressure, the alveolar pressure less the pleural pressure will cause a collapsing effect on the capillary or the vein, and now you would be really measuring the alveolar pressure, or really kind of the transpulmonary pressure, rather than the pulmonary artery occlusion pressure or the left atrial pressure. So this can be very hard to detect. Probably the best way, I think, is if you've got imaging of the patient. Barring severe hypovolemia, if the tip of the pulmonary artery catheter is below the level of the left atrium, you really should be in Zone 3. But there are clues that you are in Zone 1 or Zone 2 in a patient who is, again, totally passive with the ventilator. If the respiratory changes in the pulmonary artery occlusion pressure exceed the respiratory changes in the PA diastolic pressure, then the catheter is likely in Zone 1 or Zone 2. And the reason is because in those patients, the pulmonary artery occlusion pressure is tracking the alveolar pressure, which is an intra-alveolar vessel, rather than the pleural pressure, which is the extra-alveolar vessels. Again, the pleural pressure, the extra-alveolar vessels, would be manifest in the pulmonary arterial diastolic pressure. So again, that applies only to patients that are totally passive with the ventilator. Otherwise, this can be very difficult to determine. So again, interpreting the pulmonary artery occlusion pressure, to do it accurately, you have to do it in conjunction with an ECG. This is very similar for the CVP. The waveforms should be essentially identical, although because of the long catheter, again it's 110 centimeters, plus the column of blood to the left atrium, the waveform can certainly be damped. So It's rare to see the C wave, although you can. But certainly you should be able to see the A and the V wave if the catheter is appropriately placed. And again, if you aren't seeing adequate A and V waves, this could be a marker that you are measuring alveolar pressure and you are in zone 1 or zone 2 physiology. And there's actually well-documented cases of patients who have kind of a dampened, flattened wedge pressure because the pulmonary artery catheter is lodged in zone 2 physiology, and the patient receives some blood or some crystalloid and re-expands their vascular space, and then physiologically shifts the pulmonary artery catheter from zone 2 to zone 3 physiology, and then the A and the V waves come up beautifully. So the analysis is similar to the CVP. You've got your A wave, which is left atrial contraction. The C wave, if you're lucky enough to see, is the bowing back of the mitral valve into the left atrium during systole. You have the Z point between the A and the C wave. You've got the X descent, which results the drop in left atrial pressure with the mitral annulus being pulled towards the apex during systole. And during that time, pulmonary venous inflow is accelerated and pressure begins to increase during the end of ventricular systole. The pulmonary venous inflow into the left atrium increases, so you begin the V wave, and then at the initiation of diastole, the mitral valve opens and pressure once again drops, and you get the Y descent. Okay, it's important to realize that because of the length of the catheter, this tends to be shifted leftward relative to the ECG as compared to the central venous pressure tracing. The principles are the same though. When you line up the 12 lead and the pulmonary artery occlusion pressure tracing, the first positive deflection of the wedge pressure following the ECG P wave will be your A wave. Okay? The C wave you'll be lucky to see, and the V wave is almost always completely, or should be completely, after repolarization of the left ventricle. So the V wave is well after the T wave. And this becomes important when you're interpreting wedge pressures that look a little bit weird, or you could be having problems with partial wedging, or if you've got mitral regurgitation and tall V waves. Distinguishing that from a pulmonary arterial systolic pressure can be difficult and sometimes even impossible, but a true V wave should come after the ECG T wave. If there's a positive deflection occurring during the T wave of the ECG, you need to think of potentially partial wedging. It's the same as the CVP here. The deflection of the pulmonary artery occlusion pressure that is true end diastolic pressure of the left atrium is again the Z point here, and that is at the end of atrial contraction just prior to the onset of ventricular systole. So interpreting the pulmonary artery occlusion pressure. So we've talked at length about getting an accurate measurement of the pulmonary artery occlusion pressure and how it's subject to changes in intrathoracic pressure and west zone physiology. But once you have obtained an accurately measured pulmonary artery occlusion pressure, you now need to know what it means. And you have to understand its physiologic underpinnings to know what it means. The occlusion pressure is frequently used as a marker of LV filling, preload, left ventricular end diastolic volume, as well as left ventricular performance. But there's important limitations to this. Further, the pulmonary artery occlusion pressure is often used to distinguish cardiac or hydrostatic pulmonary edema from non-cardiogenic or non-hydrostatic or capillary leak pulmonary edema. But this is really fraught with problems, and I'll talk about each of these in turn. So, interpretation of the pulmonary artery occlusion pressure. So there's a fairly poor correlation. Multiple studies have shown a fairly poor, if not no, correlation between the pulmonary artery occlusion pressure and the left ventricular end diastolic volume. And really, what we really want to know is the LVEDV, the end diastolic volume, because this is the true preload of the left ventricle. And the reason for this poor correlation we talked about in Chapter 2 is that the LV end diastolic pressure volume relationship is typically exponential in shape. And there's extreme variability between patients in the shape of this curve and even within a given patient during a disease course or with various interventions. You add vasoactive medicines, diuretics, mechanical ventilation will change this pressure-volume relationship. So a wedge of 15 in a patient at time A could be very different from a wedge of 15 in a patient at time B, depending on what you've done to them. So you always have to interpret the pulmonary artery occlusion pressure in light of the patient's clinical status and in light of the clinical interventions that you've performed. So just a quick review from Chapter 2. This is the end diastolic pressure-volume relationship. Okay. It's the change in pressure in response to the change in volume. This is the elastance. So if you look at this patient, this is diastolic dysfunction, so there's a shift up and to the left of the end diastolic pressure-volume relationship. So you can see that for the same end diastolic volume between these two patients, there's going to be a very different pulmonary artery occlusion pressure. This is the end diastolic pressure that you're trying to measure at the end of the A wave before the C wave, i.e. at the Z point of your pulmonary artery occlusion pressure. This pressure could mean very different volumes in very different patients. And there's multiple causes for both acute and chronic diastolic abnormalities, and there's no standardized pressure-volume relationship for all patients. It just doesn't exist. So trying to apply a single wedge pressure for all patients is going to lead you astray. So one very common or very commonly cited example of this phenomenon is left ventricular ischemia. So if I were to place a catheter in the left ventricle and measured a systole, this is the pressure tracing I would kind of get. It's kind of poorly drawn because of my PowerPoint skills. But essentially this point here is your end diastolic pressure, and this is going to be considered, this curve is going to be considered to be the gold standard for your LVEDP because, as I've said, the catheter is right in the left ventricle. So this would be like a catheter through the groin or through a radial artery placed all the way down into the left ventricle. So this is a superimposed pulmonary artery occlusion pressure. So this is your wedge pressure, and this is the end diastolic pressure that you're estimating. Again, this is the pulmonary artery occlusion pressure, which is used as a surrogate of your left atrial pressure, which is then a surrogate of your left ventricular pressure. So there's usually fairly good correlation between the two, and you can see the pressure increase in the left ventricular cavity with atrial systole. So atrial contraction forces blood in, pressure goes up, and then just before systole you have your end diastolic pressure, and the same holds true for your pulmonary artery occlusion pressure. But what happens with acute LV ischemia? Well, this pressure goes way up, and this is a result of a decrease in compliance of your left ventricle. So now this pressure differential, your LVEDP estimate from a wedge pressure or pulmonary artery occlusion pressure is going to be way lower than the actual LVEDP. So as I mentioned, the pressure waveform increases out of proportion, and the abrupt increase in LV pressure causes the mitral valve to close prematurely, and the pulmonary artery catheter is essentially hidden from or misses this increase in the LV cavity pressure. Okay, so that was one example. There's other examples such as aortic regurgitation, other valvulopathies, but you have to bear in mind that the left atrial pressure as a surrogate for your left ventricular pressure is fraught with problems. And then once you do know your left, if you do have a good measurement of your left ventricular pressure, there can be a poor correlation between your left ventricular pressure and your left ventricular volume. So moving on to the final aspect of this portion of the talk. I know it's running a bit long, but this is important. And this is a discussion of the pulmonary capillary pressure, which I think a lot of people consider to be equivalent to the pulmonary artery occlusion pressure, but it is quite different. When capillary pressure, and really any capillary in the body, exceeds roughly 20 millimeters of mercury, fluid tends to extrude into the interstitial space. Okay, so this is a rough capillary pressure. If you took an average capillary in the body, would have a pressure of roughly 20 millimeters of mercury. People are kind of amazed that the hydrostatic pressure within a tiny little capillary can be 20 millimeters of mercury, which might actually be 10 times greater than the pressure in your right atrium, and how it can withstand that. And the reason is because of Laplace's law, and what's truly important is the tension capillary endothelial cells, and because the radius of the capillary is so small, remember that Laplace's law is the transmural pressure multiplied by the radius. Even though the transmural pressure of a capillary might be 20 millimeters of mercury or so, the radius is so small that the tension on those endothelial cells is actually very small, so they can tolerate hydrostatic pressures up to 20. So it's commonly taught that therefore it's commonly taught that pulmonary artery occlusion pressure above 20 millimeters of mercury can distinguish hydrostatic from non-hydrostatic, i.e. capillary leak pulmonary edema. This is not true. I feel like everything I'm telling you about the pulmonary artery catheter is just not true, and I'm trying to convince you that it's your friend. Nevertheless, you should not be using the pulmonary artery catheter as a measurement or as a way of distinguishing hydrostatic edema from non-hydrostatic edema. And the reason that hydrostatic edema may exist with a low pulmonary artery occlusion pressure and non-hydrostatic edema can exist with a high pulmonary artery occlusion pressure. Hydrostatic, that is pressure-related pulmonary edema, may exist in the setting of a low pulmonary artery occlusion pressure if the elevation in the pulmonary artery occlusion pressure is transient, like an acute ischemic event. LV ischemia can be very abrupt and short-lived. It can be on the order of 5 minutes. And there's some neat papers, I think, in the mid-90s by this guy, Stephen Sharkey, who also wrote a really cool book on the pulmonary artery catheter, who showed that with just very transient episodes of LV ischemia, the pulmonary artery occlusion pressure can go from, a normal value up to 40 millimeters of mercury and then back down in less than 5 minutes. And you can flash with that, obviously. And then you could miss that, and if you measured the occlusion pressure, it could be reading normal and the patient could be in frank pulmonary edema, and you'd then start thinking that the patient had non-hydrostatic pulmonary edema, which would be completely false. Or, as I've mentioned, if there's an increase in pulmonary venous resistance. In this next slide, I'm going to talk about this phenomenon of increased pulmonary venous resistance, because I think it's often forgotten, and we sort of think increased pulmonary venous resistance is pulmonary venous occlusive disease, and that's very rare, and we never see it. But actually, increased pulmonary venous resistance can be commonly seen in critically ill patients, and lots of insults increase pulmonary venous resistance, including increased pleural pressure. ARDS has been shown to increase pulmonary venous resistance, particularly in the kind of chronic or quote-unquote fibrosing stage of ARDS. Hypoxemia has been shown to increase pulmonary venous resistance in and of itself, so don't forget about pulmonary venous resistance in critically ill patients. So this slide is going to get a little bit busy, but this is the best way that I can illustrate to you this phenomenon of the pulmonary capillary pressure. So this is a simplified schematic of the pulmonary circuit. I apologize for using electrical analogies here, but it's commonly used in the literature, and I think it's actually a fairly good analogy. So this is your right ventricle, your left ventricle. So what do all these little symbols mean? Well, this is, remember, this is the capacitance bed from undergrad physics. So this is a capacitance sign, or a capacitor. This is a pulmonary arterial capacitance bed. This is your pulmonary arterial resistance. This is your pulmonary capillary capacitance bed, pulmonary venous resistance, and then your pulmonary venous capacitance bed. And this is essentially your wedge pressure, your J1, the first junction of the pulmonary veins in the left atrium. This is actually the wedge pressure you're measuring in this when the blood gets to this capacitance bed. So this is the capillary pressure that you're interested in, quote-unquote, teasing out hydrostatic from non-hydrostatic pulmonary edema. And here is the pulmonary artery occlusion pressure. So in this cartoon, I want you to consider you've now floated this pulmonary artery catheter into the right ventricle and out into the pulmonary bed here, and you're measuring the pressure across this convoluted, very bright and squiggly circuit that I have highlighted for you today. I kind of made this in a bit of a haze. I was also listening to Fleetwood Mac, so I apologize for the audacity of this slide. So this is your pulmonary artery catheter, as I mentioned. Now measure this little packet of blood moving across the circuit. Let's see that again. So your pulmonary artery catheter is in, the balloon is down, so you're measuring your pulmonary artery pressures, and you're going to measure this little packet of blood flying across the pulmonary circuit. And as I mentioned, you're measuring the resistance, the total resistance across this pulmonary bed as you eject the stroke volume of the right ventricle into the circuit, and you get your your pulmonary diastolic pressure, your pulmonary systolic pressure, your dicrotic notch, and the pressure comes down. And now what I want to illustrate for you is, imagine at the tip of your pulmonary artery catheter here, keep your eye right there, you're going to inflate your balloon, okay? So now you've instantaneously ceased blood flow across this circuit. And we're going to now follow that same packet of blood during a cessation of blood flow. So this is this packet of blood. You've inflated your balloon here, so this marks your balloon occlusion. So as this packet of blood flows across the pulmonary circuit, it's going to initially go through your pulmonary arterial capacitance and resistance, and you will have a drop in pressure. And this pressure drop here is representative of the resistance of the pulmonary arterial tree, and that's the slope of this line, and it's represents most of the pressure drop across this pulmonary circuit, because about 2/3 of your pulmonary vascular resistance is due to pulmonary arterial resistance in normals. And then as the blood flow equilibrates with your pulmonary capillary capacitance bed, you then get this inflection point. And this inflection point is here, and this is actually the pulmonary capillary pressure. But this is all happening very fast, and the blood flow continues. This packet of blood has continued across your pulmonary venous resistor, and you continue to have more of a pressure drop, so that's represented by this red slope, until the packet of blood reaches your pulmonary venous capacitance bed, and you've now leveled off and you've measured your wedge pressure. So this drop in the pressure is actually a summation of the change in pressure as a result of the pulmonary arterial resistance bed, the pulmonary capacitance bed, and then the pulmonary venous bed. And again, this pressure drop from balloon occlusion to wedge pressure, 2/3 of this drop is your arterial venous, this 2/3 of this drop is your arterial resistor, okay, and then the final third of this drop is your venous resistor. So this change between your pulmonary capillary pressure and your wedge pressure, with a 40%, with 1/3 of your total pulmonary vascular resistance being due to venous resistance, they can be close, but they're going to be different, and the difference is going to be a function of your pulmonary venous resistance. Okay? But imagine if that pulmonary venous resistance is high. So going back to, well, I don't want to go through this whole thing again. Imagine this is a high resistor, and so instead of 1/3 or 30% or 40% of your total pulmonary vascular resistance, say it's 50%. Well, then the pressure drop between your pulmonary capillary capacitance bed, or your pulmonary capillary pressure, and your pulmonary artery occlusion pressure, that pressure drop is going to be rather great. So you could actually have a very high pulmonary capillary pressure, but a low recorded wedge pressure, or low recorded pulmonary artery occlusion pressure. And as I mentioned, pulmonary venous resistance increases in a lot of common clinical states. So as I mentioned, the occlusion pressure may be normal or low, but there could be a very high capillary pressure, and therefore, despite a normal pulmonary artery occlusion pressure, you could have a very high capillary pressure and therefore have hydrostatic pulmonary edema in the face of normal or low occlusion pressure. Okay? The converse is true as well. A high pulmonary occlusion pressure can be complicated by non-hydrostatic pulmonary edema. So for example, a patient with ARDS complicated by a septic cardiomyopathy. The ARDS will be causing capillary leak syndrome, but at the same time, this patient may have a high pulmonary artery occlusion pressure as a result of their septic cardiomyopathy. So this is all just to illustrate that the use of the pulmonary artery occlusion pressure to differentiate hydrostatic from capillary leak edema is fraught with problems and should always be interpreted with consideration for the patient's clinical history. And that is, thank you for paying attention for a whole 40 minutes. That is my diatribe on the pulmonary artery occlusion pressure. It is probably my least favorite number from the pulmonary artery catheter. And I think that's voiced by Dr. Jeffrey Guy, who does podcasts on critical care medicine, which I find very informative and helpful, and he feels the same way. It's his least favorite number from the pulmonary catheter, and it's should be for the reasons I've mentioned. It's hard to measure, and when you do measure it appropriately, it's hard to interpret. Thanks.